So this study has a long title here, which is the anti-inflammatory efficacy of letermovir in adults with HIV-1 and asymptomatic cytomegalovirus who are on suppressive ART and its effects on chronic inflammation, HIV persistence, and other clinical outcomes, otherwise termed the ELICIT study. I can't exactly figure out what ELICIT stands for out of all those words in this title, but I do like the name ELICIT, especially even though you spell it a little differently, we are collecting some illicit samples in this in this study. And so that is a way in which I can remember this title. So Michael often likes to have a slide at the beginning of presentations that is called jargon, I think, sort of a jargon dictionary. And so I don't have mine outlined as a dictionary, but I have picked out some keywords here that I want to just introduce by way of introducing the study. So the first word that may look really unfamiliar is letermovir. Letermovir is the medicine that we're testing in this study. It is a medicine that stops CMV from making copies of itself. CMV is a virus that we will talk about a lot more during the presentation. HIV-1 on suppressive ART, what does that mean? HIV-1 is the HIV that most people in this country and most of the world, except for Western Africa, have. And suppressive ART means you're taking your antiretroviral therapy and that your virus number, otherwise called a viral load, is below 50 copies per milliliter, which means when your doctor tells you that you are undetectable or that your viral load is suppressed, that's what that refers to. So for this study, we want people who have HIV and are on suppressive ART, meaning they have a suppressed viral load, and who have what's called asymptomatic cytomegalovirus. So what does that mean? Asymptomatic means no symptoms. And so those of you who are long-term survivors of HIV from sort of the earlier AIDS era may know people or may yourselves have had cytomegalovirus or CMV that was not asymptomatic, that instead caused bad disease like blindness or encephalitis, meaning people could have been in comas or had very bad experiences in the hospital. But for most people, cytomegalovirus doesn't cause symptoms, and most people with HIV do have CMV or cytomegalovirus, and I'll talk more about that later. And so those are the two things that are required basically for being in this study is having HIV on and being suppressed in terms of your viral load, and also having been exposed to CMV, which we will test you for, although about 90% of people with HIV have been exposed to CMV in the past. Okay, and then we're studying the effect of this medicine, letermovir, on chronic inflammation, HIV persistence, and other clinical outcomes. I'll go into great detail about what that means. What is chronic inflammation? What is HIV persistence? And what are the clinical outcomes we're talking about?
Elizabeth, we have a question. Bill,
oh, great.
You want to ask it?
Yes. If I've never been told that I have asymptomatic CMV, and if you're saying that I'm a long-term survivor, obviously, most people living with HIV have this. Was that correct?
That's right, Bill. You got it.
Wouldn't my doctor at the medicine clinic tell me that I have asymptomatic CMV?
I think it's very unlikely your doctor would tell you, Bill. It's possible, since you're a long-term survivor, that back in the early days, someone might have tested you for CMV, for a CMV antibody, and somewhere back in your records, that information would be there. And so we wouldn't even have to test you. but it's not something that your doctor would routinely talk about because it's not something that would affect your life very much from day to day. Although I'm going to tell you how we think it probably is affecting your life every day, but not in a way that your doctor would think to sort of tell you about it.
Mm. And
does that make sense, Bill? Sorry, Michael.
No, go ahead.
Well, it just seems to me that any of the symptoms of HIV that anybody develops, they would be told so they're aware.
Mm-hmm. Yeah, so I wouldn't call CMV a symptom of HIV. It's actually another virus.
I can't think of the word that's used around possible illnesses that you can get with HIV.
Oh, like an opportunistic infection,
yes,
maybe?
If we have an opportunistic infection, it seems like our doctors would tell us just so we're aware.
Yeah,
would it help to talk about the fact that, just to say, Bill, I think would it help that probably about 60% of the overall general US population and closer to, maybe 80-90% of the world have CMV, and it doesn't cause problems in the vast majority of people, and almost nobody has been tested for it or knows that they have it because it doesn't cause problems in most people.
And I think, Bill, you and I both remember in the bad old days, people would get CMV retinitis, but only when their T cells were very, very low. So in this modern era where everybody has no viral load and relatively high T cells, we haven't had to worry about it for a very long time. It was only a problem when it got out of hand, when your T cells were very low.
Mm.
Mm-hmm.
So I don't think, Bill, that it is irresponsible of your doctor not to test you for it or tell you about it.
I wasn't implying that.
Sorry, I didn't mean to put words in your mouth, but I do think
I'm totally happy with the treatment.
But I do think that well, I'm also a provider, so I'm just thinking about all the people I haven't been testing for CMV or telling them that about it. But I do think this is a great opportunity in the study for us to find out, is CMV truly, causing people with HIV problems, and would treating it help? So those are the main questions that we're addressing with this study. And I think, and I would love it, Bill, if you were interested in being in the study.
Well, I don't know if I have it. So.
Yeah.
Well, we can tell you. We can tell you.
Okay.
Yeah.
Well, thank you for answering the question.
Of course.
I had a question. I had a question too. I wanted to ask, how is CMV transmitted between people?
Oh, that's coming, Michael. That's
coming. Is it? Okay, cool. I just wanted to make sure we had that.
Yeah, we do. Good. Okay, so here's our outline. Why are we doing this study? Why is inflammation a problem in people who are undetectable? What is CMV, and why do we think treating it might help? And in that section is how is it transmitted?
Great.
What is letermovir? Is it safe? If I'm in the study, how long will I take it? Will everyone take it? What are the ways that CMV might be causing problems, and how will we measure changes? And then we'll talk about special study populations and enrollment plans for this study. Okay, so why are we doing this study? So this plot can be kind of hard to read. So let me just sort of let me just tell you what to look at. I can't think of quite the right word of what I'm being, but on this top line here is the HIV negative group, and on the bottom here are people with HIV. And this graph is telling us, depending on when you were diagnosed, assuming that you were age 21 when you were diagnosed, how much longer, how many more years would you expect to live after that? And what we see is that in people who don't have HIV, that over the years that has gone up. So people are living longer who don't have HIV, but that people who do have HIV, this gap between the people without and people with HIV has been narrowing over time as care and medications have been getting better. However, there is still a gap. Is that while these life expectations are similar and that people are living into their, this would be 70s and 80s, that for some reason, even though, people are suppressed on their medications and we have good medications, there is some reason why people with HIV are not living quite as long. And then in this plot, which is a little harder even to follow, and these are both from the man who is leading this protocol, Peter Hunt at UCSF. These are his slides. But what this shows is that, up here, we just looked at, this is survival, but down on the bottom here is comorbidity-free years. And so what this is saying is that people who have HIV are sicker earlier than people who don't have HIV. And that this is especially bad for people who had low CD4 counts before they got on therapy. And so the summary here is that people with HIV are still dying sooner and getting sicker faster despite effective treatment against the HIV virus. And so there's a question of sort of, why is this? And what we find is that people with HIV, despite having a suppressed viral load, seem to have more diabetes, seem to have more heart disease, more liver disease, and more cancer. Why is that happening? And what's CMV got to do with it? So a lot of people think that the reason that people with HIV have these comorbidities, despite their virus being suppressed, is that the HIV living in the cells quietly is still revving up the immune system. And that revving up of the immune system, immunologists and doctors call inflammation. But the people who are leading this study think that there may be another piece of the puzzle. It's not just HIV that's revving up the immune system, that it might also be CMV, and that the combination of CMV and HIV together might be an especially inflammatory combination. So what's CMV got to do with it? All right, so what is CMV? CMV is a herpes virus. And like other herpes virus, that means once you've got it for life. So think about HSV1 and HSV2, herpes simplex viruses. So once you've got genital herpes, even though it goes away for a time, you often get those lesions back, or cold sores coming back over time. Also, chickenpox virus, think about how that comes back later in life as shingles. So CMV is just one of those herpes viruses and follows that same pattern, is that once you're infected with it, it lives in your immune system, generally doesn't cause problems, but has the ability to sort of come back. Okay, so how is CMV, let me make sure I didn't skip one. How is CMV spread? So CMV is spread or transmitted from person to person through saliva and breast milk. And so many people are infected during childhood. So if you think about, countries where children, there are big families, or where children spend a lot of time with one another, or children who are in daycare, there's a lot of evidence that just children being together with saliva going around is enough to pretty efficiently spread CMV. On the other hand, when women with CMV breastfeed their children, there is a fair amount of CMV shedding that goes on in the breast milk. And so children, newborns can be infected as well. And so many of the people who are going to be infected during their lifetimes are infected during childhood. We often also see that sometimes children will get infected when they're in their congregate settings, and the mother who has been CMV negative will then later become infected by the child as well. In our population, which often many of the people who are living with HIV, a large percentage of those people are also men who have sex with men. The CMV can be spread through sexual fluids and seems to be transmitted quite well, in fact, in that setting. And so there is some thought that perhaps that is why the sort of the percentage of those with HIV who also have CMV is so high.
I have a question that relates to the CMV. So when it's in our body, is it latent, like how we say HIV is latent, sleeping inside the cells, or is it actually still active? Or don't we know the answer to that?
Great question, Michael. We don't know. I think truly we don't know the answer to that. As far as, you know, can you measure it in the blood? Like, are people viremic, generally speaking? The answer would be no. Most people are not viremic at all at any time. And maybe they are when they're first infected, but I sort of doubt it. But CMV is present in so many different types of tissues that it's that are also not that easy to measure. That it's very hard to know whether CMV is just sort of constantly doing some sort of low-level replication and that the immune system is just constantly holding it back, or if there are events that sort of cause a latent CMV to wake up. I would say the majority of the field believes that there's a latent form that reactivates. I would say I'm more in the camp of, I think CMV is probably constantly trying to replicate. Yeah.
So Liz, back in the way long ago, CMV in the blood only occurred if your T cells were really, 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 really low. And in fact, there were studies back once again in the ancient days where we didn't have decent treatment, and people who had T cells that were low tended to stay low, and we tried to treat CMV. But that was a very different time than now.
That's right. That's right. And over at the SCCA, when I'm treating people with bone marrow transplants, they truly get CMV in the blood in high numbers when they have no immune system. But as far as sort of like, you know, in a daily sense, for those who have relatively healthy immune systems, you know, what is actually happening? If we were able to zoom in like on our, you know, smooth muscle tissues or our endothelial cells and watch.
We don't know, do we?
No, we don't know. We don't have a clue. Yeah. Yeah. Same could be said for herpes simplex virus as well. Is we really don't know whether, you know, people are constantly dripping a little bit of herpes from their neurons and the immune system is just, you know, there to contain it, or if, you know, there are events where suddenly replication starts. And I apologize to CAB members if we have gotten too much into the scientific weeds with that, but maybe some of you also find it interesting. So, yeah.
Well, we have someone else asking about, is the study going to be doing CMV PCR or CMV IG testing? So,
great questions. Yeah. Okay. Yeah. So we have a mixed audience for sure. So we will be doing, so I guess maybe if I'll answer that really quickly, and then I'll go into more detail when we get through what are the actual samples we're collecting in the study. So we will test the IG once, which is antibody test, to know whether you have CMV or not. And then the rest of the testing of your samples will be done by PCR.
Awesome.
All right. So what is CMV infection like? Like we were just alluding to, in most people, CMV causes no symptoms at all. You never know that you have CMV. However, it is the leading cause of deafness in newborns. It causes disease and death in solid organ and transplant patients, like bone marrow transplant, and causes retinitis, blindness, and encephalitis in people with AIDS. And luckily, I haven't had to see that, but I think Ann and Cher have seen too much of that.
And what is encephalitis?
That is inflammation of the brain.
Mm-hmm.
So good question, Michael. That is like someone comes in really, really confused, sort of in a stupor or a coma, a lot of times, not knowing where they are or what's going on, or sometimes just not even able to speak. You might think they've had a stroke, but they haven't. Yeah.
Yeah. Thanks.
Sure. All right. So sort of getting to what Michael was asking, is, so when do we see, bad CMV disease? We're only seeing it then in neonates, so newborns, transplant patients, and people with AIDS. And they all share something in common, which is immunocompromise. And so what seems to happen is that when the immune system drops very low is when CMV can really wreak havoc. However, in people who have healthy immune systems, and even in people who do not have HIV, we see that CMV has a very special relationship with the human immune system. That 10 to 40% of a certain kind of T cells are CMV specific. So what that means is, our T cells have a huge, what we call repertoire of things that they can recognize. So the idea that one pathogen would attract 10% of the T cell's attention, or especially 40% of the T cell's attention, is just crazy. It means that this has just captured the imagination of our immune systems. And as we age, even those of us without HIV, what we see is that this, what we call immunodominance, meaning this focus on CMV of our immune systems, becomes even more profound, meaning that number 10 to 40% can be even larger, to where much of your T cell repertoire is focused on CMV. And we think that is how people who are elderly start having sort of a bad immune system, which is what we call immunosenescence, meaning old immune system. Okay, so in other words, our bodies spend a lot of time and energy fighting CMV, a disproportionate amount of time and energy. All right, so all this immune attention causes inflammation in people without HIV, but in people, and so in people, I think what I'm meaning to say here is, no, I do mean in people without HIV. Mm-hmm. Yes. So in people without, this is also true for people with HIV, but also in people without HIV, CMV is associated with earlier death. So meaning people who have been exposed to CMV, like myself, by the way, we die sooner because we have CMV. We have increased heart attacks and strokes. We are more likely to get diabetes. We are more likely to have cognitive dysfunction, depression, and general frailty. But in people with HIV, these effects seem to be magnified. So what I'm showing you here, I mean, this is not typical necessarily of everything, but this is just an illustration. What we're looking at right here is the aorta. This is the big artery in the heart. And here it is in someone who doesn't have HIV. And here it is in someone who does have HIV. And inflammation is showing up as red, fiery stuff. And what they're showing here is just how much red, fiery stuff there is in the HIV positive person versus the HIV negative person. And that this is typical of the findings that they had in this paper, where they were finding CMV plaques in the aorta. So a word about CMV and HIV persistence. So what is HIV persistence? I think a lot of people in the CAB will know something about the term HIV reservoir, which refers to the amount of cells, CD4 cells in the body, T cells, that have HIV living latent inside of them. And so for those of us who are thinking about HIV cure, thinking about getting rid of all of those cells that are infected with HIV, which is called the HIV reservoir, is something we think about a lot. And in order to cure someone, you would need to be able to get rid of that reservoir. On the other hand, CMV may be driving persistence or even growth of the HIV reservoir. And so this is something that I think could also be potentially pretty motivating for the study. So if you imagine that, remember how I showed that slide about how much of our immune system is focused on CMV. So if you imagine that you have one of your many cells that is focused on CMV, happens to have HIV integrated inside of the chromosome. So in other words, this is part of the HIV reservoir, this T cell, this CD4 T cell, and it recognizes CMV because it is a CMV specific cell. It sees CMV, and then it multiplies in response to that, which is just the normal thing that a T cell does when it sees the virus that it's supposed to respond to. Then you see growth of the reservoir. The cell that has that HIV inside of it multiplies. And there is certainly evidence that the HIV reservoir has a I won't say necessarily a majority, but in a lot of people, a lot of the HIV reservoir cells are made up of CMV specific cells. So if we could stop the CMV from presenting itself so much to the reservoir cells, perhaps we could stop this process of the reservoir growing, and perhaps it would shrink more readily. So this is one of the things that the study is going to be following. Okay, so what about letermovir? So letermovir stops CMV from making copies of itself. It's FDA approved. It's clinically tested in bone marrow transplant patients. So I think this is an important point, because when I reviewed the consent form for the study, there are many things that are listed as common side effects of letermovir that are very similar to the things that people experience when they are transplant patients, like nausea, like vomiting, etc. And I really am not convinced that letermovir actually causes nausea. I think this is just a reflection of the population in which the drug was studied. So I do think that will be important to keep in mind when thinking about whether you want to participate or not, and you're reading the consent form, is that we don't know yet how people with HIV who don't have, cancer, who just received a bunch of chemo and a transplant will do with this medicine. My sense is that there will be very few side effects. and the medication seems to be very safe. So, and the reason why we haven't done a study like this before is because the only medications that we had before letermovir was recently FDA approved were very toxic drugs. And so we didn't think that the benefit was worth the risk of giving you the CMV medicines that we had in the past.
How is this medicine given?
Good question. This medicine is given as a pill. It's taken once a day. We don't know yet, because there is a limited supply of the medicine, whether we'll be getting the 480 milligram tablets or whether we'll be getting the 240 milligram tablets. If we get the smaller tablets, you'll be asked to take 2 once a day. If we get the larger ones, it'll be once a day. It's also possible that we might be, getting a mixture, such that like sometimes we'll be asking you to take 1 a day and sometimes we'll be asking you to take 2 small ones once a day. But that's the, so not too big, and just an oral pill. The other thing I wanted to make sure that people understood, and that has changed about the study since when Anne presented it, is that this is an open label randomized study. So initially they wanted to do this as a placebo-controlled trial, but I think there was a problem getting the placebo pills. And so what this means is that if you are interested in being in the study, we will screen you just like we always do. We'll do the entry visit, and at the entry visit, we will randomize you. And that means that you will have a 50% chance that we will say, you're going to be taking the letermovir medicine, and you will get a box of medicine that says, letermovir, this is what you're taking. There's also a 50% chance that you will be randomized to not taking letermovir. And in that case, we are not going to give you a placebo. We're going to give you nothing. So we will still ask that you come to all of the study visits. You won't have to take a medicine, but do keep that in mind when you're agreeing to do it, is that if you're only doing it to get the medicine, that there's a 50% chance that you will not get it. And we really hope that you will continue to be in the study. Because we do need a comparison. Right.
And do we know about any other drug interactions that the letermovir might have? Nelson was asking about integrase-based regimens, but do we know anything about the interactions between drugs?
We do, and there is a little bit of a list, but mainly this one doesn't have too many interactions. The main medications of concern, I would say, are that there are a few HIV medications that if people have more of a resistance profile, like for example, etravirine is one medicine that we can't give with letermovir, and that one I do have a few patients on who have a bad resistance history.
Do you know the brand name for that? Because not a lot of us will know the generic name.
That is a good point. Would somebody mind Googling that? Because I can't Google with my
Intalin.
Intalins or Intellins. Is that yeah.
Thanks, Nelson.
It's the big chalky one. I could tell you that. But we would be more than happy to go through your med list with you if you think you might be interested.
Mm-hmm. And Laurie was asking a question here. How does this medication differ from valganciclovir, which is what she says she thinks they use to treat CMV retinitis? And why do they expect this to have a different impact on CMV?
Great question. Thank you, Laurie. Valganciclovir is the oral form of a medicine called ganciclovir, which is the very first medicine that we have for CMV. Unfortunately, ganciclovir causes cell counts to drop in a lot of people, sometimes pretty dramatically. And so that is something that we can't put people on for a year, which is basically what we're wanting to do with the letermovir, is have people on for 48 weeks of treatment. And so I that's what I was sort of speaking about when I was saying that, you know, the older medicines that we have are just too risky for trying to do a study like this, for us to be trying to monitor everybody's blood counts for, you know, for a year. On the other hand, Lori, you're also exactly right that if you had CMV retinitis, I would treat you with valganciclovir and I would not treat you with letermovir. And that is because if someone has true CMV disease and they have lots and lots of virus in their body, letermovir actually has, it's sort of like an HIV medicine. It is somewhat easier for the CMV virus to develop resistance to letermovir than it is to valganciclovir. And so I wouldn't want to put letermovir up against a retinitis level of virus. But in someone who, you know, is without symptoms from CMV and is otherwise, you know, pretty healthy, I think the level of CMV that we're talking about going on in their body is just not high enough to cause those resistance kind of problems. And I would really prefer to have someone on a drug that I feel like it's very safe to have them on for a year. Does that answer the question, Lori?
Yeah, she said thank you.
Sure. Okay, so study design, 48 weeks on treatment, so almost a year, with 12 weeks of follow-up after that. And the idea is that to really get these markers of inflammation down, it's not something that we're going to see with a very short period of treatment. Is that we anticipate this will take a while to see changes in things like, you know, cardiac inflammation, in markers of diabetes, in neurocognitive, meaning thinking sort of changes, or frailty sort of changes. So, all right, so the ELICIT study design, 60 weeks total. We'll have a screening, an entry visit, and a treatment start visit. So that's a little different, is that we'll have one extra visit there at the beginning to actually start the treatment. And then we will have 10 follow-up visits. Those tend to fall either every 4 or 8 weeks. So I'd say compared to some studies, this is fairly frequent in the number of visits. Who can join? Adults 40 years and older. And I want everyone to notice that there is no upper limit on the age for this study. And so the people who designed the study are especially interested in the effect of CMV as people age. And so whereas many of our studies have been restrictive in the past as far as not allowing older adults to participate, we are really seeking older adults in this study. And so would love to have you, and no youngsters allowed, 40 and up. We need people who are on ART. So most ART is okay, but there are a few exceptions that we can talk about with you personally in terms of whether that could possibly exclude you. With virus 50 copies or below in the last year. I say some exceptions allowed because if you've had one that went high, depending on how high it is, we might still be able to get you in the study. CMV antibody needs to be positive, but that's not something that you need to know in advance. We will get that test at screening. If you have Hep B or Hep C, it can't be active. So if you've had treated Hep C, that's no problem. And you can't be in the REPRIEVE study at the same time. We'll do medical history. We'll do physical exams. We'll ask you about your adherence to the letermovir. We'll do blood draws, rectal swabs, oral rinses, and we'll collect genital secretions. I'll talk more about the samples here in a second. We'll also do mood and mental health surveys, sleep surveys, cognitive tests. Those of you who know Share Story, these are the games that you play with Share when you come to clinic. Trail making, digit tests. We'll also do physical function tests. Don't worry, we're not gonna put you on a treadmill. This is just like, we have this thing that you squeeze as hard as you can. We ask you to sit in a chair and then stand up and then sit back down. And there's a 4-meter walk. So meter, remember, is a little less than a yard. So this is not very far. We're just timing to see how fast you can walk 4 meters. Okay. This study is really for people who would like to come see us fairly often. And when they come, enjoy answering questions and doing games and challenging activities. So if you like to interact and sort of have something to do, we have plenty of things for you to do at the UW Positive Research on this study. Why are we doing all this testing? So remember the things that we are thinking that CMV might cause in you, and the things that we think that treating CMV might help. So we think CMV might cause increased cardiovascular events. So the biomarkers that we can measure in your blood to see if treating CMV might make that less likely, those are measured in your blood. We think that treating the CMV might make diabetes less likely, and we can measure that in your blood. We can also measure your HIV reservoir in your blood, and we'll be able to tell you if your reservoir might be a little bit smaller at the end of the study. The only way for us to test whether this has helped your cognitive function, so your ability to think, we can't test that in your blood. So we have to do these cognitive tests, these games, to see if you have gotten any better or have not gotten any worse. For depression, we measure that with the mood surveys. And for frailty, we measure that with the chair rise, meaning getting up and down out of the chair, and with the grip strength. So that's why we need to do all of these games and all of these surveys. We can't just take your blood to measure some of these things.
I have a question. What if, what if someone already has diabetes? Can they be in the study?
Yes. So the hope would be maybe the diabetes would get better. Maybe the blood sugar control would get better.
Okay.
Yeah.
Cool. Thanks.
Unless RBI, did I just put my foot in my mouth? I'm pretty sure diabetes isn't an exclusion.
I think it can be anything that is any underlying other problems, as long as they're well controlled and wouldn't get in the way of measuring things. So like, I think statin doses for people who are on statins are fine, but they just can't be moving around. And somebody can't have like an acute problem with their brain that would make it challenging to evaluate how they're thinking. So if somebody had just recently had a stroke or something like that, or I think that's the general.
Or if their diabetes is, or if their diabetes is like also out of control at the moment or needing adjustment in their meds. Yeah.
Mm-hmm. We have another interesting question. Nelson was asking, is the study industry sponsored? And will volunteers be provided drug if the study is shown to help after the study is done? Because the drug would be off-label for HIV inflammation and would be very costly off-label. And he concludes, I think this is a very important study.
Great. So thank you for that question, Nelson. I guess fortunately and unfortunately, the study is not sponsored by Merck, who owns letermovir. It's sponsored by the NIH, the National Institutes of Health, as I think all of our studies are. Merck is sort of cooperating, I think, in the sense that they are providing the drug for the study. And Nelson is right that this drug is extremely expensive because it was only recently FDA approved in transplant, and it is off-label for the purposes of treating inflammation and HIV. So the hope would be, this is a phase 2 study, I want to say. So the hope would be that we would find some positive results from this study, which would lead to a further larger clinical trial, which might get FDA labeling for HIV, at which point insurance would pay for it, and et cetera. But at the moment, there is no immediate plan for people who are in the study to be provided with letermovir once it's over, if the study shows positive results. I wish I could provide letermovir.
Thank you.
Yeah, I'm sorry.
Probably important to add too that we might not know the results of the study for a little while, because a lot of them are like these fancy, not clinical blood tests, but these biomarkers for other things. And so I would say it's likely that we won't know until people are off the study. Like some of these ACTG studies on reservoir and things like that, where the results get reported a little bit later, but will come back obviously to the CAB and to the participants.
And there'll, depending on when people get enrolled, other people will be finishing later or earlier and that kind of thing too. So yes, but a great question. Okay, so while this testing, so also, why do we need saliva, rectal, and genital secretions from people? I think for some people, this is no big deal, but maybe for other people, this is more of a big deal. And so sort of explaining why we're doing this, I think, is important, and gets at what Michael and me and Anne were sort of talking about, which is that CMV is rarely found in the blood unless there is extreme compromise of the immune system. So, when people have retinitis, the blindness caused by CMV, when people have AIDS, yes, you will find CMV in the blood, but in people who have suppressed viral loads and good CD4 counts, you shouldn't find CMV in the blood very often. However, CMV, there have been a bunch of studies done actually by one of the study co-chairs named Sarah Gianella. CMV is found frequently in like 40 to 50% of semen samples from men who have HIV. And then CMV is found less often in saliva, but much more often than in blood. We are still learning, I would say, about CMV in cis and transgender women's genital secretions. That is not a population that has been studied very much yet. And so that's one of the reasons that we are really hoping to enroll women in this study. But to find out if letermovir is really decreasing the amount of CMV that is replicating or making copies of itself in the body, we need to take samples from where the CMV is. And so we can't, if we look in the blood, we're not going to be seeing CMV before the letermovir or CMV after the letermovir. It's really the semen and maybe the vaginal fluid where the money is, and hopefully some in the saliva as well. And so that is why we're asking you for these illicit samples. And we will try to accommodate people being able to collect these at home and bring them to us. But we also, like in the good old days, can set you up in Madison Clinic if we need to collect these samples. Okay. All right. So that brings me to our target enrollment population. So like I was saying, there is no upper age limit on this study, and we would really like to see some older adults be enrolled in the study. And we would really also like to acknowledge and apologize to the community that has been excluded from these trials for so long, is that, there are reasons why other studies have excluded people who are older, but this is sort of our chance to learn about the older population, and we would love to have you participate in the study. In terms of actual hard enrollment targets, there are two groups that we are required to enroll. And so the protocol authors really believe strongly that people with lower CD4 counts will benefit more from this intervention than people with higher CD4 counts. And so half of the people that we enroll have to have a CD4 count less than 350. So for those of you, especially the long-term survivors who, have had such a hard time getting your CD4 count up, this is really a good sort of opportunity to be in a study, because again, many of our studies exclude people who have CD4 counts lower than 350. This is a chance where we really are recruiting people with CD4 counts lower than 350, is that if we do not enroll half with CD4 counts lower than 350, they will put a hard stop on our ability to enroll people, and we won't be able to enroll anyone else until we have enrolled someone with a low CD4 count. The other hard stop is that we need 1/3 of our participants to be cis women or trans women, and specifically on hormones. So even trans women who have had surgery and are no longer on hormones are not eligible as women for this study. We need cis women and trans women on hormones to be 1/3. And the way that they are giving us slots is that we have 2 slots that we can have now, but they will not give us any more slots unless at least one of these people has a CD4 count less than 350. And then once we get up to our second block of 2 more slots, at least one of those people has to be a cis or trans woman in order for us to be given more slots. So,
do we have any requirements around race?
In general, they would like for us to be enrolling, I can't remember the exact percentage, but they're encouraging us to enroll non-white people, but there wasn't a hard requirement on that as of yet for enrollment.
Okay, thank you.
Sure. So, so if you have a higher CD4 count and you are not a cis or trans woman, please be patient with us in terms of when we can enroll you. And also please encourage your female and low CD4 friends to join us. Okay, so I think that is all the pre-prepared sort of presentation that I have. Are there other questions that people were holding back or that are in the chat that I haven't even been following the chat?
Don't worry, there's lots there. You can catch up on that too.
Michael and I have been trying to help with the chat too.
Yeah, I think it's been going well. We encourage you all to speak up. If you have your question, you don't have to type them into the box if you want. If is there any follow-up questions that you want to ask, please ask them directly. How many people are in this study in total is my question.
Good question. So let me pull out my binder here. I want to say it's 120 that they're trying to enroll, but let me double check that. The one thing I didn't mention that relates to enrollment is that they do want to make sure that this works before they enroll the full study. So there will be, they're going to try to enroll 40 people to start with, and then do an analysis to see if they see any sort of effect. And if they do see that it looks like it might be working, then they will continue. But if it looks like the medicine is doing nothing, then they will stop the study early.
Great. Bill, did you have a question?
180 participants is what they're aiming for.
Cool.
So I had typed, do you have a list of conditions that make people ineligible?
I do. I don't know if you want me to sort of go through them, Michael, or if
I don't mind. I think it would be of interest, at least to Bill, and I think the rest of us would be interested to hear. Okay.
So you can't have had a change in your HIV medicine in the 12 weeks prior. There are certain drug regimens that we talked about that you can't be taking. You can't have had 2 or more HIV viral loads greater than 200 in the last year. You can't have had a febrile illness within 30 days of joining. You can't have taken anything that treats CMV in the 90 days prior to joining. You can't be taking immunosuppressive or immunomodulatory drugs, with the exception of nasal steroids or inhaled steroids. So if you're taking like a drug for like rheumatoid arthritis or something like that, that would be something we would need to take a look at. You can't be pregnant or breastfeeding. You can't have a history of an arrhythmia on your EKG, meaning like a heart problem where you had an abnormal rhythm. So that includes atrial tachycardia or ventricular tachycardia. And so a common one of those is something called AFib. If anybody's had AFib, that would be a problem. A history of heart enlargement or heart disease from when you were a child, what's called congenital heart disease. Active drug or alcohol use that would interfere with being in the study. Hospitalization or bad illness in the 90 days prior. We talked about active hepatitis B or hepatitis C. Presence or history of conditions that could account for impaired neuropsychological performance, including prolonged head injury with loss of consciousness, severe learning disability, or psychosis. Basically, those are things that the investigator would need to sort of carefully consider as far as, can we tell, can you take those tests and do those games that we're talking about well enough for us to be able to tell, whether or not you've improved or not improved over time on the study? And are those stable and not worsening? Yeah, and a history of multi-class HIV drug resistance, such that in the opinion of the investigator, we would have a really hard time finding you another regimen if you were to lose your viral suppression during the study. Although I really feel like you shouldn't lose your viral suppression during the study. so that is the list, which is really not very exclusionary. I don't feel like. Compensation. Yes. So like most of our studies, unfortunately, the compensation is embarrassingly low. And this has to do with the fact that we are funded by the government, the National Institutes of Health, and not by pharma. And so I still think that's a good thing in the sense that we are not, tied to any sort of pharmaceutical bias. But on the other hand, it makes it hard to adequately reimburse you guys for your time. And so we really appreciate when you participate in the studies that you are doing so because you care clearly, and not because you're making money by any means. But we pay $20 per visit. And when you give us what we call invasive samples, so meaning the rectal samples or the genital secretions, we will give you an extra $5 for each of those. Granted, they are worth much more, but so you have the potential to make to get $30 per visit. Don't forget that we can always reimburse you for parking, which can cost $20 a day at the NJB parking lot. Mm-hmm. And we can provide you with food vouchers for the cafeteria. But again, we realize that none of that is, makes this, financially worth your time. And we appreciate every one of you.
Mm-hmm.
Yeah. I was wondering about the likelihood that there'll be lower adherence and higher dropout in the placebo arm, since people are going to know they're not taking the actual med. And if you're randomizing like 2-to-1, or if it's, how it's powered, so that if there is less adherence and higher dropout, that you'll still be able to have a meaningful result.
Yeah, that's a great question. And if you are on the video, I'm sorry, I can't see you, or I can't figure out where the voice is coming from. But
it's Lori. I just have my picture up.
Okay. So I am worried about that. There is no compensation for, or like nothing built into the statistical scheme for that. It's a 50-50 randomization. So I hope that doesn't happen, but I suspect that it might.
Mm-hmm. And Eve, you have a question as well? Did you want to ask?
Yeah, I was wondering. Hello.
Hello.
Eve Gearbox from the East Coast. I was wondering how many sites are scheduled to conduct this study?
I don't know how many are going to join. I think at the moment there are about 8 who are participating. RBI, do you happen to know? Are you still on?
Yeah, I'm still on. I think that there are probably half of the US sites signed up. I think this is, correct me if I'm wrong, this is a domestic study only, is that right?
I don't know.
I think it is. Let me look. I'll look on the ACTG website and I can get back to you.
Thank you.
Thank you.
And Bill, did you have another question?
No.
No? Okay. Anyone else? Questions? In the meantime, you'll see I also loaded up into the chat our study materials, at least before they've gone to the IRB, but to give you guys a chance to overlook them as well. I put those into the chat, at least images of them, so you can give a look. And if you had any comments or critiques of those, you could please share them either here, or if you want to share them with me, you can send them to my email. That's why I always like to make sure that when we have a study that we get the materials out to you all for your input on that.
And I really want to thank everybody for attending. Thank you for taking your Tuesday evening to listen to me talk about CMV, and for thinking about enrolling or encouraging others. Yeah, thank you so much.
And if you want to stop sharing your screen, we can
sure.
Always, oops, there we go. Someone just joining here at the last minute. Dante, yes, but if you stare, we can kind of see a gallery to say goodbye if we don't have any other questions.
Yes, it's showing me new share, but I'm trying to figure out how to stop.
It should be up at the top. I think.
Stop share. There we go.
An answer to whomever asked how many sites were participating. There are 15 sites that are currently registered. That does not mean that more won't join, but it looks like as of right now, it's us, it's the 2 Cornell sites, University of Colorado, UCLA Cares, Vanderbilt, Alabama, Houston, Case Western, Cincinnati, WashU in St. Louis, us, and Mass General Hospital in Boston.
So it's all domestic.
It's all domestic. And I think that's because of the specimen shipping and the drug, because they're also, because this drug is so expensive, instead of, oftentimes for studies, they send us drug when we start the study, and then we have a supply on hand for our first participant. For this study, when someone registers for the study, we get like an overnight shipment of the drug that's for that particular participant.
Wow. And I know,
so I think that they just can't make that logistics, logistics, as well as getting PBMCs or peripheral blood mononuclear cells back to us. And then the other thing, I know Liz didn't mention, there's also a couple of sub-studies that are not yet open, but will be in consideration if we pass the first 40 participants and it looks like the drug is working against inflammation. And those are things like a cardiac PET scan to look and see if this has changed kind of inflammation, a fat biopsy, and a lumbar puncture. So those are all optional procedures that people could sign up for. In addition, again, you can participate in the base study without signing up for all of those, but people can choose to do all or some of those. I personally think those are kind of interesting because you might get to learn something about your own body and get kind of real-time feedback, especially the PET CT does, they're really cool pictures. But in any case, I think some of those things are hard to do in more resource constrained settings.
And so we kind of can know that something's happening. If a sub-study opens, it kind of means the drug is working. We might not know in which way, but they wouldn't be opening those sub-studies if there wasn't seeing something to go. So that would be kind of cluing off something's happening. That's good.
Yeah, I'm not entirely sure how this is going to work from a logistical standpoint yet in terms of like when they're going to push play on the sub-studies with relationship to the analysis of the first 40 people. I think, we want to make sure we're not pausing the study for too long. So it makes sense to get those sub-studies up and going. We have to do some preparation. We have to get the radiologists to do the PET scans all ready to work with us. We have to prepare to do fat biopsies. Lumbar punctures are easier because we can do those in the UW positive space. So yeah. I think it's stay tuned.
I don't know about the rest of you, how you feel, but this sort of study excites me because if it does show that it's having some effect, I love the breadth of what it might be having effect on. Imagine if we see it helping with diabetes, or if we see it reducing the reservoir, which is one of the major goals around cure research. I just think there's a lot behind this study that makes it exciting to do. And, no promises, it's science after all, but like it's hopeful, you know what I mean? Because it sort of makes sense in my mind that, oh, well, we have this other virus that isn't really being addressed. And we know that other viruses, there's always this sort of relationship between them. And so it would make sense to me that CMV might be doing something like this. And then, where we saw the inflammation, those great pictures that Elizabeth shared with us and about the aorta, like if it took care of that stuff, that would be what would be taking care of those heart attacks that we keep on having and seeing people have. I just think it's one of those studies that gives me a lot of hope. I'm hoping that it comes true, that we don't just find that this is a big goose egg at the end. But it's important to know either way, in my opinion. It's important to know that it is not doing anything, or at least that this treatment can't help that. So I don't know how the rest of you feel, but I'm excited about this sort of stuff. There's a hand up. I don't see whose hand it was.
I think it's Cher. His hand up.
Oh, Cher, go ahead.
Well, Nelson mentioned that volunteered to help with enrollment, but I think this study, more than most of ours, because of the way it's constructed, the fact that it's relatively small numbers, and we are going to need people who are ready to join us, but maybe have to wait for a while. So we're going to kind of finesse this, but it will rely much more on the community with this particular study than we normally do. Normally we open it up, we see who's interested, and we go forward, we enroll them. In this study, we will open it up, we'll see who's interested. You may come in now or a little bit later.
Right.
But the reality is after 40 people are, if it works after 40, this would be a study you might want to be involved in, to take a 50-50 shot at getting a very expensive drug to control CMV. So there is sort of an incentive for participating, but also we've been very, very fortunate to have the kindness of the community support research. And so that's important now to understand that we're going to need that with this one. And you're understanding that we're dealing with the same, the ACTG mechanism, which might take longer than we all want.
True.
True. Well, I appreciate the presentation tonight because, I haven't heard about CMV since the old days. So I just assumed it was a thing of the past. And I'm sure I'm not the only one in the community that thinks that. And I think what this does, it shines a spotlight on things that are affecting our community that we're not talking about, like frailty. And so this is really educational for, advocates like me, for my community, to know what's out there and what's affecting my community living with HIV. So I do appreciate presentations like that. And I really thank Michael for doing that frailty group a couple months ago.
Yeah, last month.
Oh, was it only last month?
It's only last month. Yes.
In isolation, it seems like 2 years ago.
I know. Well, I wanted to thank you all for joining us tonight. I think it was another great meeting, although it was small. There were a lot of people who normally join us who didn't get to join us tonight. I think it's our job to make sure they hear about these, especially a lot of them I know are often excluded from our trials. So I'm going to make a personal effort to make sure they find out about this one, since they didn't get to hear it from the direct from the source. But I want to thank you all for taking your time out. We're nearly at time, so it's a perfect place to end.